Okay. Hit record now. And I'm Robin Thomas, and I founded a community I call Living Well Connections about, gosh, how long ago? I think it's about 5 years now. I founded it in order to help people who are passionate about wellness and about health, but more about being well in holistic ways, different alternatives on the regular allopathic medicine. I started it with a few practitioners and it has expanded. Now we have over 500 members. It's totally free. There's no charge to join. And it's we have a free Facebook group, a private Facebook group, which is a great place for conversations. We just like to share knowledge, share our own knowledges, because different practitioners have different talents. And we also just have a community just to support each other and just know it's a safe place. So that's Living Well Connections. And I was playing around with technology, and Eventbrite suggested I needed to do Zapier. So anyone who signed up automatically got on my email list. I'm sorry, I didn't know that was going to happen. But if anyone is on my email list and wants to get off, of course, you can unsubscribe. But it actually allows you to come on. It shows the Facebook group where you can come on. And today, well, we have wonderful once a month events where a practitioner or someone who has a lot of personal knowledge about health and wellness comes and gives a short presentation and time to afterwards for questions. And today, Dr. Shaina Holman is our sponsored practitioner. Thank you so much. And you want me to introduce you? I will.
If you want to, I can give a little bit about my own background too, whatever.
Why don't you tell a little bit about your background? I have an introduction, but it's very long. Maybe you can tell us what's important to you.
Sure. Okay, well, let me go ahead and share my screen then, and let me know if this works, because I'm still kind of new to all this. Can you see my screen?
Yes, we can.
Great. Yeah, so a little bit about me. I'm a general dentist. I practice in North Chapel Hill in the Chapel Hill North Shopping Center. I moved to Chapel Hill when I was 16 years old and met my husband in high school. So all of our family is in Chapel Hill. I ended up going to Duke for undergrad. I studied anthropology, and then I ended up going to University of Maryland for dental school, where I did my D.D.S degree, but I did a dual degree program, so I also got a Ph.D. My Ph.D. work was all in infant suck physiology. We were trying to understand the role of oral sensory nerves in triggering the swallow reflex, which is typically thought to not have to rely on any input from the oral cavity. So I studied that and loved it. We use an infant pig model to better understand infant people. They have very similar anatomy. And after my PhD work, I went back to dental school, finished dental school, and graduated with both degrees. After that, I did a 1-year residency at the VA hospital in Maryland, where I got more advanced training with surgery. And then me and my husband decided to move back home to Chapel Hill. And I started my practice about 1.5 years after I finished my residency program. So I've had my own practice now for almost 3 years. I definitely have a strong interest in the airway and in oral motor function. A lot of that comes from my PhD background, but also I am very crunchy myself and very holistically minded, and I like to get to the root of problems and not just fix teeth. Another thing that's interesting about my practice is I have an infant tongue tie clinic on Mondays that's multidisciplinary. So I'll talk a little bit about that as well. But in my practice, I see all ages, literally from birth. I have a 4-year-old or 4-day-old I have to see after this, up until end of life. So I do everything from a full mouth extraction and dentures to snipping a baby's tongue tie. So very good. Well, I'll just go ahead. I'm going to be talking a lot today about the airway, not so much about teeth exactly, a little bit more indirectly about teeth, but I think it's really important for dentists to be screening patients for sleep apnea, or what we refer to as sleep disordered breathing, but any type of trouble with their breathing and sleeping, because it is so related to overall health. And as a dentist, I'm literally staring down somebody's airway. So I'm in a good opportunity, or in a good position, to see signs and symptoms of sleep apnea, or again, sleep disordered breathing. So I'll talk a little bit today about sleep apnea, about signs and symptoms I'm looking for as a dentist, and about the many different treatment options if you are someone that is struggling with proper breathing, whether again it's apnea or not. And I'll give you some resources in the community of people that you can talk to, or suggest any of your clients or loved ones talk to if they're having any of these similar struggles. This is a really big topic, a really, really big topic. So, and I'm so familiar with it that I just don't want to lose anyone along the way. So please feel free to interject with questions. It's a bit hard for me to keep up with the chat window. So Robin, if you're able to help me with that, I'd appreciate it, but you can interrupt me. That is absolutely fine. So with obstructive sleep apnea, what that is referring to is people that are having trouble breathing while they're sleeping, and because something is in the way. When you are sleeping, you should have your lips closed. Your tongue should rest on the roof of your mouth, not the floor of your mouth. And that's pretty much your normal sleep posture. Snoring is not normal. I have a lot of patients that on my intake paperwork as a new patient will say, I have it written in there, do you snore? And they'll say the normal amount of snoring. There is no normal amount. That is a sign of an obstruction. But that's kind of your normal posture when you sleep. So people can have apnea or hypopnea. Apnea is when you go periods of time without breathing at all. Some of you might have experienced sleeping next to a loved one that has apnea, and it is terrifying to listen to. It literally sounds like they might die. Hypopnea refers to when you're not getting enough oxygen. So you haven't completely stopped breathing, but you're not getting a sufficient enough amount of oxygen to really restore your body and give it what it needs. So you can have very similar symptoms, whether you have apnea or hypopnea. And the big reason why all this is important is because when your quality of your breathing is affected, your whole body is affected. And many of you might already be aware of a lot of this, but with adults that aren't getting sufficient amount of oxygen, it can trigger your body to crave carbohydrates because your body needs energy. So this might be a person that is gaining weight and they're hungry all the time and they just can't figure out why. And it could be related to their poor quality of sleep. It could be a child that has ADHD because their brain is not able to restore itself at night because, again, they have an obstruction. So you can really see in many ways how it affects your whole body. Another big one, and we'll talk about this a little bit later, but your blood sugar. So it's really interesting to see the relationship between obesity and diabetes and obstructive sleep apnea. A lot of people just think it's all due to weight gain, and you've gained a lot of weight and now you're going to have diabetes and you're going to have high blood pressure and sleep apnea, but it can also work the other way around. If you have an obstruction to your breathing and you're not getting enough oxygen, that causes your blood sugar to spike. And that can put the extra strain on your heart. And that might not have anything to do with weight. Actually, a lot of people with sleep apnea has nothing to do with their weight at all, and a lot to do with how they're breathing and how their jaws have developed. Of course, if you have a lot of extra fat in your neck, that's going to put pressure and could cause sleep apnea, or fat that's incorporated in your tongue. But it's not all about just obesity.
So I bet they do. I'd offer you a Tylenol, but I took my last one this morning. I had a headache too.
Okay, so with obstructive sleep apnea, again, I'm looking at a lot of different symptoms of apnea. So with my adults, I ask a lot more questions. Oh, is there somebody who needs to get muted? Sorry.
Babies. Oh.
Robin, are you able to mute people?
It's just a paper.
Oh, there we go. Okay. So with obstructive sleep apnea, again, I'm looking at a lot of symptoms as a dentist. I have a lot of extra questions in my medical history form than most dentists. I ask about snoring. You can be a primary snorer, meaning that's your only issue, but often snoring is a sign of some form of airway obstruction. Some people just have a really large tongue, which, as you can imagine, if there's no space in your mouth for your tongue, it can easily collapse back when you're sleeping. So it's hard to teach a tongue to rest on the roof of your mouth if your tongue just takes up your whole mouth. Why would you have a large tongue? It's usually related to weight. A large part of your tongue is fat. So for people that are already overweight, that can be a big obstacle to work around. A sign of a tongue that's maybe a little too large for your mouth is scalloping around the border of your tongue, because it literally forms to your teeth. It has these little notches all along it. Another sign I see of people that have a large tongue is when they bite their teeth together, their teeth have a space here. There's an opening. It's an open bite, or their teeth are flaring out because of that pressure of their tongue pushing on their teeth. I ask all my patients, pretty much all my patients, about mouth breathing. About mouth breathing, because when you are at rest, like all of you are right now watching my presentation, your lips should be closed and you should be nasal breathing. When you're sleeping, your lips should be closed and you should be nasal breathing. There's a lot of signs of the teeth and mouth on people that are not nasal breathing. When you are nasal breathing, your tongue, like we talked about, should be resting on the roof of your mouth. So if you're mouth breathing, usually your tongue's resting on the floor of your mouth, which makes the roof of your mouth come in more vaulted. It makes your teeth narrower. It makes your teeth more crowded in the front. And it makes your face actually develop longer. So it's not unusual for me to walk into a room and kind of already know if someone's a mouth breather. Not to mention they would be even sitting there currently breathing through their mouth in the chair. But you can often tell the signs and symptoms just by looking at how someone's jaws have developed. Other signs of sleep apnea, of course, you might just completely hear the pauses in breathing when someone's sleeping, which again is very scary. Daytime sleepiness, that's more of a thing for adults, where they'll find, what I usually ask my patients is, if you're in the middle of the afternoon and you're just sitting around watching TV, where you'd be pretty likely to just doze off, in the right environment. And these patients will tell you, oh yeah, I'm always just kind of nodding to sleep in the afternoon. Tongue ties. We will talk a little bit more about a tongue tie. But a tongue tie to me is a sign of sleep apnea, because if your tongue is pinned down to the floor of your mouth, it's more likely to collapse back as you're sleeping, and it might be unable for you, or you might be physically unable to have your tongue rest on the roof of your mouth like it should. A tongue tie is referring to the little string under your tongue, the frenulum. Right there, that little white band. On some people, it comes up to the tip of their tongue. When I look again at every patient's tongue anatomy for tongue ties, and it's amazing how many people are almost completely tongue tied and no one has ever even looked. That is not a thing dentists tend to check for. That's not something we're taught about at all in school. I also look for signs that there's a nasal obstruction. So if someone is mouth breathing, is it because you can't breathe through your nose? Are you physically unable to? Like, do you have a deviated septum, or again, like just really prominent turbinates in your nose? Can make it very difficult. I look for people who have chronic allergies. So some people will say, well, that they mouth breathe because their nose is always congested. And we'll talk a little bit more about that. That's one of those chicken and the egg kind of things. Definitely I look for medical history, people with heart problems, diabetes, acid reflux, grinding your teeth. All those things all go very hand in hand with sleep apnea. And like I mentioned, that long face, the vaulted palate, the crowding of the teeth. So I'm looking at all of these things when I assess my dental patients, because I want to see if they have any of these signs that might point towards sleep apnea. I really don't even make a night guard for grinding your teeth until I'm pretty sure that this is not an issue at all. Some of my patients can tell me they only grind their teeth for stress. None of these other things are an issue, and I'll make them a night guard. But if they have any amount of any of these things, I'm usually suggesting a sleep study before making a night guard. Yeah. Any questions about some of these? We're going to go in a little bit more detail on a lot of these topics. But in children, apnea can look very different. Children, I always ask if they're snoring at night. Are they grinding their teeth? Kids can grind their teeth when they go through growth spurts, but I've seen kids that have completely ground their teeth into the nerves of their teeth, where they have exposed like red dots of their nerves across their front teeth. Reflux. Reflux is really hard to assess in a child. And again, it's normally something I can just see signs of. Like if a child has worn their teeth all the way into the nerve, that's usually not just grinding. You need some acid and some grinding of their teeth to get them that low. But you can sometimes ask a little kid, you know, do you get the taste of throw up in your mouth sometimes? And they'll like, oh yeah. And you say, well, how often? Most of the time. And the parent is like, wait, what? You know? So sometimes it's just about asking the right question. With kids, you see a classic just dark circles under their eyes. Again, kind of a long face. They might be standing there with their mouth open. Again, there's almost a look to the facial features of a child suffering with sleep apnea. It really is like this, and they just look tired. ADHD is a big one. There's a lot of debate about what percentage of ADHD is really just sleep apnea in children. I have even talked to some of my colleagues that are MDs and psychiatrists about diagnosing children with ADHD and why isn't it just part of the protocol to do a sleep study or ask questions about sleep. And she was just like, yeah, good point. I don't know. And so I, you know, again, as a parent myself, like before maybe looking into medication and other things, gosh, it'd be so easy just to go to ENT, check for tonsils, adenoids, you know, maybe do a sleep study or something to explore that.
There was
Yes.
one question in the chat, I think kind of refers a little bit to that. When you suggest a sleep study, do you do your own sleep studies or do you refer people out?
Good question. As dentists, there are certain dentists in North Carolina, we are held to our board, of course. So in different states, different dentists can do different things. In some states, a dentist can administer a sleep study, a home sleep study, like send you home with a sleep test, but they can't diagnose it. In North Carolina, the board has an opinion statement that it is outside the scope of practice for a dentist to even administer it, even just send you home with a test, even if we're not diagnosing it, which I think is a little ridiculous. I know a lot of dentists that kind of get around that in various ways, but I'm someone that's just a very by the book, straight and narrow person. So I do not have send people home with a sleep study. What I do is refer to a sleep medicine doctor or have them talk to their own medical doctor. There's some medical doctors that have their own sleep tests, like if you know Ken Stone, a slower medicine. I know he has his own sleep study, home sleep test that he'll send patients home with. But I really refer to the MD to sign off on it, as again, the board kind of says is more of their realm than mine. It is unfortunate though, because I feel like if I could send my patients home with a sleep test, they'd be more likely to take it and more likely to get the information they need, because often people are with me when I'm talking about this in the dental chair and then they get home and forget. So I wish it was a little easier to facilitate that process, but it's not. Yeah, bedwetting in children is another sign of sleep apnea. In adults, interestingly, adults will wake up a lot at night and they'll think they have to go to the bathroom and they don't. That's another kind of indication that maybe something's off with sleep. But in kids, they will just bedwet beyond the timing that's normal. So again, there can be a lot of reasons why a child might wet the bed. But this is a definite one to explore. A tongue tie, again, often missed. Some of my parents will tell me it was mentioned at birth or mentioned with they had trouble breastfeeding, but they didn't address it. And sometimes they have addressed it. And it's just that there's still lingering issues with the airway. Large tonsils and adenoids on kids. It's very common for a child's adenoids and tonsils to be very large and then just kind of naturally get smaller with age. But if they're so large a child can't breathe, it might be worth it to do surgery to take them out. There's a lot of challenges with communicating with ENTs about that, because sometimes the ENT is like, well, they're borderline large. And you're like, okay, but if they have every single sign and symptom of sleep apnea, does that tip your thoughts at all? The ENTs just tend to be surgeons. They look down at airway, what can I cut out? And so they're not really spending as much time looking at all the minutia like this. So sometimes those are hard conversations to have. Also, when people tell me they have chronic nasal congestion or allergies, again, I kind of wonder, is that because they're mouth breathing and their nose is just really sensitive to their environment, or is there true allergies that are present? I'll talk a little bit more about nasal breathing, but there's a lot of people out there that will tell you when you work on your nasal breathing that your allergies magically go away. even asthma. So very good. I think that's all I want to say. It is amazing when you go through this list and you start asking a parent about one or two things, and they're just like, yes, yes, yes. How did you know my child wets the bed? And how did you know they had tonsils out? And just because these things literally are like, they're all go hand in hand. And similar to adults, often you find that each one thing's being treated independently of the other. It's not uncommon for me to have adult patients that are on medication for reflux. They wear a night guard for their grinding. They have high blood pressure. They have diabetes. They literally have all the things. They take melatonin at night, and no one has ever suggested us doing a sleep study. So where to start? This is also confusing because you might have some of these issues, but there's so many different doctors that are subspecialized in this area. And honestly, these guys just don't do a good job of talking to each other. So it makes it really hard as a patient to navigate. But if I think there's an obstruction to a nasal cavity or the airway, I usually point to an ENT. And again, I kind of tell my patients, these guys are surgeons. They're going to look in your nose, look down your mouth. Is there something in the way? Can I cut it out? And that's kind of where their scope ends. But still, we need them in the loop because we need to know if there's something in the way. Sleep medicine doctors will go through a little bit more about their sleep history. They are the ones that can get, ENTs can get you a home sleep test. A sleep medicine doctor can get you a sleep test. They'll look a lot more deeply into signs and symptoms. They are going to look at your sleep hygiene, meaning how is the room when you sleep and your bedtime routine and kind of things like that too. The sleep test, they're the ones that can diagnose that sleep test and kind of figure out, is it obstructive sleep apnea or is it central? Central is kind of coming from the brain down versus something in the way. A speech and language pathologist is a key person in this process, and they are often ignored and just not brought into this at all, which I think is a huge, unfortunate part of all this. A speech and language pathologist that is specifically trained in a field called orofacial myology, and there are very few in this area, can evaluate all the functions of the tongue and lips. They look at how you're breathing. Are your lips closed when you're breathing? Where's your tongue resting when you're breathing? They will watch you swallow. They will watch you eat a cracker. They will watch you how you're making certain sounds when you're articulating certain words. So they look at all the functions of your tongue, to sum it up. And how your tongue functions impacts your airway, because again, your tongue needs to be resting on the roof of your mouth when you're resting. And you need to learn how to swallow with positioning your tongue not against your teeth, but on the roof of your mouth, because all these things will affect your jaw development. The jaw development is guided by muscles, and the biggest muscle we're talking about is your tongue, and then your lips, of course, as well. So I think they're fundamental in this process. With certain kids, if I notice that, if I don't really think there's an obstruction to the airway and it's a child that maybe has a tongue tie or that's mouth breathing, or an adult that's mouth breathing, my first person I'm pointing to is an SLP. And in their assessment, sometimes they will still go to an ENT and have the patient rule out an airway problem. An airway-centered dentist is good to have in the loop, and that's kind of what I would consider myself. The tongue tie itself, or the tongue anatomy, an SLP is not allowed to diagnose a tongue tie. An ENT can diagnose a tongue tie, but so can a dentist. And an ENT they tend to be like, unless it's pinning the tongue completely down and it's really in their face, they often miss it. So it's sometimes helpful to have a dentist in the loop that has done extra training on this, because they will be able to do a better assessment. And really, the SLP from their functional report is pretty much describing a tongue tie. They literally just can't say you're tongue tied. In a public school system, an SLP will get in trouble for even mentioning a child might be tongue tied. That's seen as that far outside their scope. So you have kids that have really obvious tongue ties, and SLP will not even look for it, or if they have looked for it, they don't feel like they can really say anything. And orthodontist is also important to have in the loop here when you're assessing airway problems, because an orthodontist is not just trained to straighten your teeth, but also guide your jaw development. So when I see a kid that has a lower jaw that's really receded like this, obviously that's going to make them very prone to sleep apnea. And I need the orthodontist to work to bring this jaw forward. Same with the palate. The palate has to have enough space for your tongue. So if it's super narrow and vaulted, or again, if it's too far back, your tongue's not going to have enough space to rest. So I need the orthodontist to expand that palate and bring it forward so that someone can rest, so the SLP can teach them where to rest their tongue, and so that all this can work. With kids, you can really easily intervene with their jaw development when they're under the age of 10 years old. Usually between 7 and 10 is where the orthodontists want to see them. But once all those bones of your jaw have fused, it's a way more complicated issue for an orthodontist to try to fix. That's where they have to like break your jaw and wire it shut and do all sorts of extensive surgery to address it. It's a hard conversation sometimes for me to have with parents where I'm trying to explain to them that their child needs early orthodontics, and they're like, they don't really need braces. They're only like 8. They'll be fine. I didn't have braces. This sounds like a money-making thing. And I'm like, no, they're airway. Like, if we, like, I don't want them to have surgery. Like, can't imagine having jaw surgery and having my mouth wired shut for a month and stuff. Like, it's so much easier just to guide that development. Same with SLPs. People will say, this sounds like all these tongue exercises are weird. But yeah, if you can teach your tongue where to rest, again, you don't have to worry about your jaws and your airway and such bigger problems. Again, the problem with a lot of these providers is they don't do a good job talking to each other. Orthodontists are taught how to straighten teeth. So you start to talk to them about palatal expansion for the sake of their tongue rest posture, and you've completely lost them. They just don't understand that part at all. Or again, dentists don't really have experience screening for all these airway issues unless they've really sought out extra education. SLPs similarly are told a lot of the stuff's outside their scope. So unless they've really sought that education, it's hard for them. Sleep medicine doctors sometimes don't really appreciate the role of all these other guys. They're very quick to say you have an obstruction, get on a CPAP. That's the gold standard. You hear them say that all the time. It's gold standard. It's the gold standard. Just do that, you'll be fine. So they kind of miss out on this stuff. And the ENT, like we talked about, is just kind of a surgeon. So they're not always looking at all the functional aspects. So this is a hard field to kind of piece everything together and try to, get to the root of the problem.
There was another question before you move on. And I want to add to it, actually. It said, why do you think there's such an increase in sleep apnea problems? And my part of the question is there really an increase, or just suddenly now we're becoming aware of this as compared to other things, especially when you're talking about, they'll focus on a lot of Band-Aid kind of treatments. I mean, but not on root cause.
Yeah, my first thoughts there are definitely, it probably correlates with some increased rates of obesity. And also the diagnosis part, again, it's just being missed. It's still so missed. So if people were being properly screened and treated and tested, it would be probably way higher than it is. Yeah. It's amazing, even the dental patients I have that literally lean back in the chair for a dental procedure and stop breathing just by leaning back,
Wow.
I know, it's crazy how it's just not diagnosed.
Thanks.
Again, I'm not allowed to diagnose sleep apnea. So I can only tell someone like, you have every single sign and symptom. I highly suggest you get this checked out. But I can't really do more than that. A treatment plan for somebody is having, again, what we kind of refer to as sleep disordered breathing, which may or may not be sleep apnea, can include so many different things, which we kind of just touched on a little bit. It can be talking to someone about their sleep patterns and keeping their room cool. It can be a tongue tie. It can be myofunctional therapy. That's the type of therapy I'm talking about with the SLP, where they teach your tongue and lips what to do. Buteyko, which I'll talk to you a little bit more about, but that's a method of training nasal breathing, again, on someone that does not have an obstruction, just doesn't do it. Orthodontic treatment, weight loss, a CPAP, which you're all pretty familiar with, and oral appliance therapy, which I'll talk to you a little bit about. That's another thing I can do as a dentist, at least, to help with opening someone's airway a little bit. So sleep hygiene, I know that's a silly term, but they're really talking about keeping your room cool at night, maybe having a cup of tea before you go to bed, maybe doing some yoga, things to de-stress, breathing exercises, keeping your room dark, maybe using some dark curtains to help improve your quality of sleep. And again, this is where maybe a sleep medicine doctor will start if they see a sleep problem, like really evaluating this and seeing if there's any quick things they can do to fix the problem. Tongue tie release is another thing that can be done to help open the airway. The idea, kind of like we just talked about with a tongue tie, again, that's talking about the string under your tongue, is that if you're very tongue tied, you can't even physically rest your tongue as it should against the roof of your mouth. So when you're sleeping, if your tongue's on the floor, your mouth, it collapses back and can cause some obstruction. So by releasing the tongue tie in coordination with working with an SLP, we can release the restriction and teach someone how to rest their tongue up and forward. This is not a good idea on someone that is overweight, because again, their tongue might have a lot of fat incorporated and their mouth might not have space for their tongue. ENTs are kind of taught that tongue tie release is worse in sleep apnea, because they don't really understand all those intricacies. How you address tongue ties is very different between an infant, child, and adult. In infants, if an infant has a tongue tie, I have to work with a lactation consultant who's going to teach mom how to latch, how to encourage that baby to form a different latch. Before and after a tongue tie release, we have to protect mom's milk supply while we're working on the quality of the latch. Make sure they have a plan in place if the baby can't eat at all. Also with infants with infants and adults with tongue ties, that string under your tongue translates tension all down your head and neck like this. You even there's been dissections of this fascia where it goes down to the tips of your toes. So sometimes I have kids that are walking on their toes because they're tongue tied. But sometimes you can see their posture where their head's more forward. Sometimes you see a baby that literally just like has traps, like a weightlifter or something. It's hard to appreciate in a baby, but sometimes they're just really, really tight and they're almost combative when they're fighting or when they're eating. So with babies, I often incorporate a massage therapist to help relax some of this tension in here, relax the tension in the floor of the mouth before I even do my assessment or release a tongue tie. In adults, sometimes they're having similar problems where they just have chronic head neck tension. They're clenching their teeth and their tongue is extremely tight. So again, sometimes I loop in a massage therapist to work with a patient before and after a tongue tie release. Sometimes there's other issues going on, like sometimes I need an SLP involved with an infant just to train their tongue again, like what to do and to get stronger after a tongue tie release. Or there's sensory processing issues where we need to involve an OT. Toddlers are difficult too when you have a tight tongue tie. They can also work with a speech and language pathologist a little bit to strengthen their tongue and to learn some exercises to help before and after a tongue tie release. But toddlers are just tricky. I mean, doing this on a child between the age of 1 to 4, they're not very cooperative. So I'm kind of hesitant to do the release unless there's truly an airway concern if they are having apnea. And in that case, I really kind of default more to the ENT for their guidance. With children and adults, working with an SLP is 100% needed in my opinion, again, to strengthen the muscles of the tongue before and after a release and teach it where to rest. And in children and adults, depending on what signs and symptoms I'm seeing, I might also have them consult with an ENT about apnea. So sometimes my concern in a child and an adult with a tongue tie is purely related to speech, purely related to a very strong gag reflex. Again, that's where you kind of get into the GI issues sometimes. They just have a really strong gag reflex. Or it's related to the ability to eat solid foods because their tongue can't move side to side. But if my concern with the tongue tie is related to their airway, then I want to loop in an ENT and say, are tonsils and adenoids also a problem? Maybe if they're being sedated, they could do the ENT could do the tongue tie release in addition to tonsils, adenoids. So it's a little bit different of a treatment plan. A lot of people wonder if they have a tongue tie. It is normal to have a frenum under your tongue. Everyone has a little string holding their tongue. The diagnosis of a tongue tie is based on your function. If you have no symptoms of it being a problem, then it's not a problem. For adults, I look at their range of motion of their tongue. I look at their anatomy. I ask questions about how they swallow or their speech, chewing, breathing, if they're having that chronic head neck tension. I look at all these things to see, is there any functional concern I have with the appearance, based on the appearance of their tongue tie. And sometimes there's not, but usually there's at least something that is happening as a result. This is not a total science, as a lot of things in medicine are not a total science. This is not black and white. It's not like your tongue tie looks like this, you have this problem, this is the solution. So you have to look at all these things and ask the right kind of questions to make sure there's no problem. In babies also, you look at their range of motion of their tongue and how it looks, but you also have to test their reflexes. I look at their jaw position. Even in babies, it's amazing. You see the mouth breathing. Like a lot of people will post cute pictures of their kids on Facebook, and the kids, doing this. Even newborns with their mouth open. That is not good. We do look at the latch to the breast, but it's not all about breastfeeding in babies, which I think is a big mistake most people make. It also affects your latch to a bottle. If your latch to the breast or bottle isn't good, you're going to get a lot of air as you're eating, have problems with reflux and gas in your body. So there's a lot of different things in babies you also have to assess for. Again, it's just not breastfeeding. Related to jaw development, what's really cool in newborns is almost all the newborns I see that are tongue-tied are retrognathic, meaning their lower jaw is really far set back, even to the point where they have like rolls in their neck and it almost looks continuous between their chin and neck. And pretty much right after release, and I'm bringing a baby back to mom, parents can tell right away that jaw has now moved forward. It's amazing. Even when they latch then to a bottle or the breast, where that lower lip would just tuck under to the bottle because it couldn't come out enough, that baby can now bring their lower lip out. So it's just incredible. I mean, it really starts from day one when it comes to a tongue tie. I often wonder with my patients, with babies especially, if by addressing the tongue tie at such a young age, encouraging that mom to do tummy time and encourage the forward development of the jaw, have we just saved this baby from a lot of these airway problems, honestly. If they can learn at that age, for a newborn, I mean, they just reflexively go to rest their tongue on the roof of their mouth. I mean, it just flies up and it goes there. And the roof of their mouth is also vaulted. It's way too tall in a newborn, So it's like, wow, by just releasing this tongue, I've brought their jaw more forward, their tongue's resting against the roof of their mouth. Potentially we've just saved this child from having to deal with a lot of future problems. And it is amazing how many of my patients with sleep apnea have tongue ties. I mean, almost all of them. I don't always recommend it get released because a lot of those patients are also overweight. So again, there's not room for their tongue in their mouth, but these things are just so related. When you talk about tongue tie releases, I'm spending a little bit more time on this topic because this is what I know and do a lot of. ENTs can do tongue tie releases and dentists. ENTs tend to use scissors because that's their tool of choice. They're surgeons. They don't tend to just have lasers on hand like dentists do. A lot of people will ask me what's better. I think it's the tool that surgeon is most comfortable with is the best one. There are certain situations with tongue ties where an ENT will even refer to me because they'll say, I can't do this with the scissors. I need you to do this with a laser because it's so tight. There's certain situations like that. I do see a lot of patients that have had releases done with scissors where it has not been a full release. And I think that's where some of the controversy comes on this topic, because a lot of babies have had tongue tie releases and then they'll say, well, that didn't fix my problem. And a lot of times it just wasn't fully done, honestly. In this picture you see, this is from Dr. Zaghi, who's an ENT in California, who's amazing. You can see what this tongue tie looked prior to surgery, how that tongue really couldn't even move up. The first surgery, it looks like there's some reattachment there, some scar tissue. And then the last picture is his surgical technique, which is a functional frenuloplasty. Dr. Zaghi's really big about using the SLP to train that tongue muscle to work really hard before and after the surgery. And he uses those tongue exercises during his surgery to make sure he has released enough tissue to get a full range of motion. I took his class and that's my technique as well. I do it with or without stitches. Most people don't want stitches, honestly, because it's kind of annoying under your tongue. You hear the term frenectomy. That's where it's usually the tissue is removed with a laser versus a frenuloplasty where stitches are put in. But again, you can appreciate from these photos, even having a good surgeon and doing this well makes a huge difference. The myofunctional therapy and the exercises make a huge difference with how these heal as well. On an infant, these are 3 of my patients from this past Monday, actually. Can you see my mouse on the screen? You can see it, right? My arrow? Yeah. Right here, these are salivary glands. These should be on the floor of the mouth. And when I'm just lifting up this baby's tongue, I am bringing up the entire floor of the mouth with it. And you talk about where that head neck tension comes from, it's from that. This one is tugging on the floor of the mouth. This frenum is very short. Sometimes they're longer, which would give a baby more range of motion, but this one's very short and restricting. This one looks very different. It's very thin. Again, it's not coming off of the lower gums like this one is. It's coming a little bit more from the bottom of the ridge or the floor of the mouth. But you can probably appreciate in this photo how close this is to the very tip of the tongue, and that tongue is pinned down. And even in this one's a little bit longer. Again, it's not pulling the floor of the mouth like the first photo, but it's longer and thicker. So when you diagnose, again, it's not just how it looks. Sometimes you can look at one and go, whoa, that has got to be causing a problem. But sometimes it's not just about looking, and parents will say, well, how tongue-tied is my baby, or what grade is it? What classification is it? I don't even like to do that. I mean, I have a scoring sheet where it describes, is it thick? Is it thin? Is it towards the tip of the tongue? Is it towards the back of the tongue? Is it attaching from the top of the lower gums or the back of the lower gums? Kind of describing it. But again, it really to me is all about how it functions. Is this baby having a problem or not? Any questions on this stuff? I know it's, again, big topic. Okay. Myofunctional therapy is what we talked about, where you have the tongue get trained to do different exercises to improve swallowing, chewing, and breathing, and speech. Myofunctional therapy can be done with a speech and language pathologist, but you can also get trained in this as a dental hygienist or a dentist. I've done training in this. I'm not certified. I do not do it on a day-to-day basis, but I got trained just because I think it's helpful to understand the field. Dental hygienists wouldn't be doing as much in speech, but they can still do a lot for the other oral motor functions. And again, it's very hard to find a speech and language pathologist in this area that is trained in this field. I have a list of, I think, 4 names, and 2 of them are not certified. 2 are. These exercises are aimed at strengthening the tongue and lip muscles. So when you're trying to teach someone to nasal breathe, for example, you usually have to also incorporate lip exercises because these people tend to have very weak lip muscles. So there's little exercises like having a string on a button, and you hold the button under your lips and pull on the string like this, and you really just try to tighten these muscles, or do exercises like wee, or roll your lips, doing those kind of exercises just purely aimed at increasing lip tone. So they give those kind of exercises. I require work with a myofunctional therapist before doing a tongue tie release in a young child or adult. It's just such a big difference in how they heal. I sometimes will do it without, and then I always feel like I regret it because it's just not as good. They can't regain their function as easily. So myofunctional therapy, again, we're not just talking about one thing here. It could be speech. It could be as a supplement with a sleep apnea treatment or a mouth breather. Someone that thrusts their tongue against their teeth when they swallow instead of positioning right. Like, they do any kind of training of the tongue and lips. I touched on this a little bit before, but there's so many benefits of nasal breathing. Even if you don't have sleep apnea, if you're just a mouth breather, and that's maybe the only thing on here that's resonating. Obviously, mouth breathing, like we've talked about, impacts your jaw development. It makes that palate vaulted. It makes your arch narrow. These are kids that are more likely to have their premolars taken out to make space for their teeth to get straight. So there's a lot of consequences of not nasal breathing, but you're also much more likely to develop sleep apnea if you're a mouth breather. The other nice thing with nasal breathing is that by just encouraging normal airflow through your nose, is it's known to reduce how prone you are to allergies or nasal congestion, and absolutely with just increasing your focus or stress level. A lot of yoga practice even talks about nasal breathing and diaphragmatic breathing, and just the importance of taking really good full breaths. But your nose is a filter. I mean, it has nitric acid in it, and it has all the well, here's everything. Air's meant to go through your nose. It's not meant to go in and out your mouth. There's some question even if mouth breathing causes the tonsils to enlarge because you're putting so much strain on them for filtering of the air. So there's some, maybe again, like chicken and the egg thing there. And again, for the sake of asthma and allergies, are you not breathing through your nose because you're congested, or are you congested because you're not breathing through your nose?
There was a question related to that on your thoughts on mouth taping at night.
Yes, I am getting to that.
Okay.
That's a great question. Buteyko is a method that is used by a few of the SLPs in the area to train nasal breathing. They talk a lot about an extended breath, like being able to breathe in through your nose and really like not need to breathe for another 30 seconds or so, and taking these long, deep breaths. But an SLP can help you work and learn the Buteyko method. And again, these people like will swear that people will work with them and no longer have to take allergy medicine, and are feeling so much better in their body just from getting really good focused breathing. But maybe something you're interested in looking at. And yeah, mouth tape. There's even an episode of Shark Tank, and I think this is the one from Shark Tank, the Somnifix. Mouth taping is used in the Buteyko method towards the end of the method. The big thing is that if you have an actual obstruction in your nose or your airway, you probably do not want to be doing this. So I would not recommend doing it just by basically buying this off of Amazon without first working with someone on your breathing techniques. But it is very hard to keep your lips closed all through the night if this is something that you're working on. So after you've mastered certain other Buteyko exercises and nasal breathing exercises and you're feeling pretty comfortable, you can walk briskly down the hallway and still be breathing through your nose. Like they have you do all these different activities. This might be something that you then want to do, and people will swear by it. I mean, that when they have their lips taped at night, as crazy as it sounds, that they are breathing so much better and sleeping so much better. So I do think it's a real thing. It's just, I think it needs to be approached pretty cautiously, again, if you have an actual obstruction. But yeah, you can buy this off of Amazon. And it doesn't need to be special tape. It could be really any tape. And then there's obstructive sleep apnea, and there's so many different treatments if you actually have obstructive sleep apnea and have that diagnosis. We all know about the CPAP, right? And everyone hates their CPAP. I have some patients that love their CPAP and say they can tell they feel so much better and it's night and day for them, but they're very hard to travel with. They're hard for sometimes your bed partner to get used to. So I also see a lot of people that won't wear it, which is scary because again, the side effects of not having enough oxygen at night are actually really scary. So it's scary that then they won't use the CPAP. The CPAP would be considered your gold standard, like we talked about. That's what ENTs and sleep medicine doctors would say is gold standard of care. Sometimes when you do a sleep study, it shows that if you sleep on your back, you have moderate to severe sleep apnea, but if you just sleep on your side, you don't even have sleep apnea. It can be that dramatic. So this pillow in the picture is kind of funny looking, I know, but it's just a pillow that will make you sleep on your side and not accidentally roll onto your back. And sometimes that's all people need. There's even these little like tubes that you can put in your nose, or a breathe right strip to just open your nasal cavity a little bit better. So sometimes in combination of something like that and sleeping on your side, or a combination of a couple of these things, will resolve your sleep apnea, especially if it's more mild. The oral appliance therapy is pretty cool. This is an appliance I've made several times. In the middle here, it's a sleep apnea appliance, or it could be a snoring appliance. But it's kind of like an acrylic mouthpiece on your upper teeth and your lower teeth, and it has a hinge between it. And the idea is you bring your lower jaw forward like this, and you can breathe better. I sometimes even will test this with patients in the chair and tell them, I'll have them lean back in the dental chair and have them breathe in through their nose a few times. And then I'll have them bring their lower jaw forward and breathe through their nose, and they'll go, whoa, that was so much easier. You know, I could really tell a difference. So sometimes a sleep appliance is helpful. Sleep appliance would not make sense if your issue with your apnea is that you have a very large neck or you have a very large tongue. That doesn't make sense. But if the issue is that your jaw is set back a little bit, then yeah, sometimes just by bringing it forward, you can breathe better. And again, it can be a combo of these things, like an oral appliance and maybe the back pillow and a nasal thing to open up, and we can avoid a CPAP entirely. I have patients that have had to have nasal surgery to address their sleep apnea for a deviated septum or a very large turbinates. And there's a whole host of other surgeries. There's laser treatments on your uvula. There's all sorts of people that remove their uvulas, like a million types of surgeries. And this is where you really need to kind of see a specialist in the field and talk through what's right for you. But most people will go straight to a CPAP. I try to encourage my patients to get their sleep studies done and figure out the diagnosis, because a lot of them are so scared they're going to need a CPAP, they won't do it. But I try to encourage people that, look, it might be as easy as sleeping on your side. It might be as easy as a mouthpiece, or it might be as easy as a breathe right strip, or mouth tape even, like it doesn't necessarily mean you're going to need a CPAP just because you get tested. And I also try to remind people about the consequences of not having enough oxygen and how really horrible that is for your body. And like, really, I know the CPAP is not fun and it's annoying, but like, if the alternative is not having enough oxygen at night, like, we really need to think about that, but it's a hard conversation. I, as a dentist, don't even have that much time with people. So again, it can kind of be hard to have this conversation quickly at the end of a dental appointment, but it's important. So again, just some takeaway notes here. Again, how you breathe is important to your overall health. Taking these long breaths through your nose is so important. Having unobstructed breathing, so you're getting enough oxygen, is so important to all the systems of your body. Many specialists are sometimes needed to really fully be able to evaluate your breathing and sleep, but just try not to get too frustrated in the process, because it is what it is, unfortunately. There's many treatment options that can help your breathing or help your sleep if you have sleep apnea. So again, if you've maybe tried one of these things and it's not working for you, you can talk to people about other options. And breathing and sleep quality are important from literally the day you're born through adulthood. Again, we see this with the newborns that already have vaulted palates and are already mouth breathing from the day they're born. And it's important to really look at all of those things. And that is it. I have my info up on the screen. I have my website and email. You can feel free to email me this picture of my kids, and I got one on the way.
Yay.
So, yeah.
That was wonderful.
Questions. Yeah.
Yeah, that was wonderful. Yeah, feel free to unmute yourself to ask questions. And I'll start with, one, I said it at the beginning before people came on, but I have a friend who has a client who has a lot of digestive issues, and she found out that she has a tongue tie, and she was wondering if there's a relationship between that. And I'm thinking, since digestion starts in the mouth, that it might very well.
Yeah, absolutely. The way you chew your food is affected by a tongue tie, so people tend not to chew their food as well. How you swallow is impacted by a tongue tie, so people tend to have a little bit more of a struggle initiating a swallow, like having to drink water every time you chew your food and need to, or doing this to swallow, because it can't move as well. So sometimes when you have trouble with swallow initiation, or the quantity of food, you can get in a lot of air when you do that. So that could potentially be related. But like we kind of talked about, tongue ties tend to also go hand in hand with large tonsils and sleep apnea. So I start to wonder about those things too, because reflux is such a huge sign in patients with sleep apnea, that if those are kind of more the things she's talking about, like air and reflux and maybe not processing her food well in her mouth, those things can be related to a tongue tie. And again, these are things that the gastroenterologists are not evaluating for. Medical doctors
she has a long history of going to the gastroenterologist, and I know from my own family that it can be very frustrating when they have such a narrow view and they're just looking at what they want to look at and they don't look holistically.
Even honestly, in babies, it's the same problem. They're having reflux, they're medicating the newborns for their reflux, and no one's looping in the lactation consultant and SLP and looking at how this baby's latch is. I mean, I've had to treat a lot of tongue-tied babies where it's like the tip of the tongue is pinned to the floor of the mouth, and this child's like 8 months and has been struggling their whole life with gas and reflux, and the chiropractor and the gastroenterologist, and it's literally like, you fix that and they're now completely fine.
That's amazing. That's
Insane.
wonderful. And yeah, so
And
many
UNC
things are connected together. I have one more question from me, and then we definitely want to open up. But I have one of my best friends, newborn, well, like I say, I think he's 2 months old now, 2.5 months old now. Grandson was born with cleft palate.
Yeah.
And I was just thinking, and I know that they're seeing a lot of different doctors and things, but I do think they're having issues with the fact that the doctors are all just looking at their own little thing and not paying attention to the whole child. Do you see babies with cleft palate, or is that a kind of a client you might see?
Yeah, I tend to not get referred those babies from the get-go, but there's a team of doctors at UNC. One is an oral surgeon and one is an MD that treat kids with cleft palates. And they actually just sent me an email yesterday saying they want to learn more about frenotomies, frenectomies, and how to best.
Oh.
A lot of it for them is timing these things together. And again, if they're looking at it only from the standpoint of breastfeeding, they might kind of blow this kind of thing off when it's kind of like, look, it's not going to make anything worse than it already is, and it might help their airway development, and this is easier to do now than later. Like, I'm looking forward to having those kind of conversations to them, like, how do you best time this? And
yeah, that was
really
I was thinking of the development, to catch it early, what you can do early. And I know they've had,
right,
they go to one doctor, they go one little kind of diagnosis or treatment plan, and they go to another, and it's different.
Now,
So
I had a colleague who had a baby referred to him, and I think the baby was 2 months old. And this baby had seen an SLP and a lactation consultant and was dropping in weight. The pediatrician was concerned, wanted the baby evaluated for a tongue tie. And when she looked in the baby's mouth, there was a cleft palate. It was completely missed. And it's just like a sign of how no one really, like, pediatricians look at, did the baby gain weight? They are that narrow. Weight gain. They don't look in the mouth at all. That's not a standard part of their thing, unless sometimes they'll catch it if it's a string at the very tip, but they are not doing any form of oral assessment. SLPs, again, like we talked about, are taught this is outside their scope. So a lot of times they're looking at how the baby's latched or what their tongue's doing, but they are not really looking under the tongue or at the roof of the mouth, their palate, or anything like that. And a lactation consultant's scope is also, they're told this is not your scope to diagnose a tongue tie. Your scope is to look at a latch, a mom's breast tissue, and their nipple damage and things like this. And it, like, how does that get missed?
Yeah, knowledge is great. I mean, bring more knowledge. That's what I say.
Yeah. I mean, it seems like it would be such a relatively easy thing to incorporate into a hospital triage, or like when they dismiss you from the hospital, or lactation consultant comes, literally just like look in the mouth and sweep your finger under their tongue and just see if it like bumps into anything, like at a minimum.
That would be a quick
but they don't
thing.
even do that. I've diagnosed newborns with tongue ties in my dental chair because the toddler sibling is here for their dental cleaning, and mom just had the babies in the corner, and the baby cries a little bit and you just see a string and you're like, oh my gosh, has anyone ever pointed that out? And nope. They're like, oh, well, breastfeeding's terrible. How, let me talk to you about this. But it's completely missed.
So Debbie, did you have a question?
I have a statement. One of the people that I read and follow is a Ayurvedic practitioner, Dr. Douillard. And that's how I learned about the mouth taping. And he has a lot of focus on the issue of teaching people nasal breathing, especially during exercise.
Yeah.
He wrote a book about the fact that people will often mouth breathe during exercise, and really gets them to try to focus on keeping their lips closed for better metabolism, better oxygenation, the whole thing. And he talked about the mouth taping. And I asked you the question about the why, and one of his thoughts on the why is because as a society, we've gone to so much soft and processed foods that our
100%.
jaws don't have a chance to develop, and it's being kind of passed down from where we used to be, where we used to eat the harder non-processed food and stuff. So
I 100% agree. That affects jaw development so much, just eating solid foods. And that's at times when I have younger dental patients, I ask the parents how the kid's eating is, meaning like, are they a picky eater? Do they like only soft things? Because sometimes a child with a tongue tie also will only eat soft food because they literally can't do the hard foods because they can't chew, they can't move their tongue around. But yeah, just having a soft diet, absolutely. All this cooked food,
those plastic squeezy things make me absolutely nuts. It's awful. They walk around just squishing food and swallowing.
I know. I was just on a podcast about baby-led weaning, but I'm a big fan of like give kids food. There's also a little tool called the Myo Munchie that's like for little kids to use, and it's just kind of a munchy thing where the idea is just literally to have them chew this thing to help guide their jaw development, because you can't have a palatal expander in a 2-year-old. That's not going to happen. And again, you might not be releasing a tongue tie in that toddler age, but if you can get them actually just like chewing on something, that can help their oral development so much. Totally.
Well, this is wonderful. I know we need to pay attention to Shaina's time because you have more patients to see, right?
Oh no, actually I'm done for the day.
Oh, you're done for the day. Okay.
Wednesdays I finish at 1. Yeah.
You're getting lots of kudos in the chat.
Thank you guys.
Yeah, so take a chance to take a look. Everyone is loving all your information. Great information, and I'd love to go visit you in person and drag my son. I might have to drag my son, but get my son there too.
Yeah.
Good.
I was one other thing I did not mention anything of, and I forgot to put this in the presentation, is there's a couple products on the market aimed at helping the airway in young children. One is the Myo Brace and the other is Healthy Start. Their idea with it is it's a removable retainer that kids would wear. It's not custom fit, but sized. And it has like a bumper under their lip, so it encourages them to increase their lip closing muscle tone. It has an area where it encourages your tongue to ramp up and rest on the roof of your mouth and expand your palate. And that can be started as early as age 2 or 3. I offer the Myo Brace at my practice because I think the Myo part of it to me is like they really emphasize myofunctional therapy along with this appliance. But a lot of dentists are getting like 2-day classes on Healthy Start, especially Healthy Start, and like just doing it. You might even hear some of this from dentists. Like I heard a commercial the other day on the radio that's like, does your kid have ADHD? Do they wet the bed? It can all be fixed. Come to our office and get this appliance. And they're kind of missing all the nuance with the airway, So like, try to also have my radar up about that. It's not just like you throw.
It could be a way to get them in the office, and then they maybe hopefully
they talk to them more about this stuff.
Hopefully they talk more. Yeah.
Another thing to be kind of listening out for is you might hear some of those commercials or things. Yeah.
Thank you so much. I'm going to have to run.
Yes, thank you.
Robin, this was wonderful as usual.
Well, thank you so much, everyone. Please come again in another month. I'm going to be speaking next month, and it's going to be. I think it's the Wednesday, not right before Thanksgiving, but the Wednesday before that. And I'll be speaking on, getting through these holidays in a healthy way. Always a good topic. So thank you for coming. It's good to see all your faces, and I appreciate it. And be well.
Thank you, Robin.